Okay, here we go. So, health supervision, learning objective number Roman numeral 1. Describe the rationale for childhood immunizations and list the immunizations currently recommended from birth through adolescence. So the rationale is to prevent illness. Yay! We like to prevent illness. Pediatricians, we're all about preventative care, right? So we are hopefully setting them up for a long, happy, healthy life. So we want to try to prevent illness and give them a good, firm foundation to grow into adulthood. The immunizations have been studied. They've been verified in those studies to be given in a certain way, in certain groups. And so that's the rationale for why they're given the way they are. That's the way they've been studied. That's the way we have data. That's why we don't break them apart into individual components like M, and R, right? We give it as MMR. That's the way it's been studied. Also, the timing of the vaccinations has been studied. We know that little bitty babies need lots of boosters because their bodies need to see that stimulus over and over again to produce a really strong response. It really takes a lot of exposure for them to make a good response. So let's quickly review the immunizations that babies are given. Now, please remember that within the CDC schedule, there's quite a bit of variability for how immunizations can be given. For instance, the child needs to receive 3 hepatitis B vaccinations over that first 9 months or so of life, according to the CDC schedule. At my office, that means we give it at birth, in the hospital, at the 1 month and the 9 month visit. But you may find on your rotation that it was given at birth, 2, 4, and 6 months, if it was given as part of the Pediarix combination vaccine. So some of those things may be a little bit differently, but for simplicity's sake, I'm going to give you our vaccination schedule at my office. But just be aware that there can be some variability. So the CDC schedule, the first vaccination they get at birth is hepatitis B, right? That reduces the risk of maternal transmission of hepatitis B from mom to infant. They get that one usually within the first 24 hours of life, sometimes more quickly, depending on if we know if mom is hepatitis B positive or negative. They are then discharged from the hospital, come back to my office for that 1 month follow-up visit, and get that second hepatitis B vaccination. At the next well-child checkup, which is often the 2 month visit, they begin that primary series of vaccines. Now, if they're going to be traveling internationally, we can give these vaccines as young as 6 weeks. But standard of care is to give them at that 2 month well-child visit. In my office, we give Pentosil, Prevnar, and the first of the rotavirus vaccines. So Pentosil is your tetanus, polio, whooping cough, Haemophilus vaccine all in one. And again, some offices give Pediarix, which is going to have that hepatitis B component, but not the Haemophilus in it, so they have to give that shot separately. My office, we give Pentosil, tetanus, polio, Haemophilus, whooping cough all in one. Then they get the pneumonia vaccine, which is your PCV vaccine. And then we get the drops in the mouth for rotavirus. The patient is going to get those same vaccines at 2, 4, and 6 months. So that's easy to remember. Primary series is the same, 2, 4, and 6 months. They're going to get immunity to whooping cough, polio, Haemophilus, pneumococcus, rotavirus, 2, 4, and 6 months, okay? Also mixed in there is that hepatitis B we talked about, so don't forget about that one. At the 9 month visit, we choose to give that last hepatitis B vaccine. If they've already had 3 of those, you don't have to worry about that. And then when they come back for 12 months, we start the next set of vaccinations, right? They're now old enough and eligible for the chickenpox vaccine, the hepatitis A vaccine, which we usually give at the 12 month visit. At 15 months, they're going to get that last Pentosil vaccine, get in that tetanus booster at that point in time. So remember our Pentosil vaccine, tetanus, polio, whooping cough, Haemophilus vaccine is given then, along with their first MMR vaccine. And then at 18 months, we give the second chickenpox and the second hepatitis A. There is some variability in the timing of that second chickenpox. It can be given any time between 18 months and 5 years of age. So you've got a wide range there. In my office, we choose to give it at 18 months. Go ahead and get that out of the way before we get them in for those kindergarten vaccines when they're going to remember that visit a lot more than at the 18-month visit. So, speaking of the kindergarten vaccines, that's the next set of major immunizations is at kindergarten. When they come in for kindergarten, assuming that they're up to date on everything else, they're going to get their second MMR vaccination. They're going to get a DTaP and a polio vaccine, and that will complete their series until they turn 10 to 11 years of age. At 10 to 11, they're going to get their Tdap. Now, everything given before that age is a big D, little t, right? DTaP. Everything above 10 to 11 is big T, little d, right? Tdap. DTaP is the little kids. Tdap, like teens. Tdap for teens is the big kids. So Tdap for teens, right? You're going to remember it. I know you are. You are. Yes, you're going to remember. Tdap for teens. Also, at that 11-year-old visit, we can start the HPV series and Menactra, along with catching up any vaccinations that they may have missed. Like some kids haven't had hepatitis A if it wasn't given in the state that they lived in when they were an adolescent. So we catch up that vaccine, any other vaccinations that they need. Also, please remember that they need a yearly flu vaccine every single year. The first time you get a flu vaccine, you have to get 2 if you're less than 8 to 9 years of age. Depends on the CDC guidelines for that year. We always check those when they come out in the fall. And a flu vaccine is recommended every single year for everyone. All right, so we've covered immunizations, birth through adolescence. Feel free to rewind that a couple times. I know I was talking kind of fast. I think it's important that you remember the general concept of immunizations, along with, the little kids are going to get the DTaP, the big kids are going to get the Tdap for teens, and the rationale behind giving immunizations. All right, let's move on to our next learning objective. General indications and contraindications of immunizations. Well, the indications are preventing illness, right? That's why we give vaccinations. We like to prevent illness. Contraindications. So the one that we run into most often is moderate to severe illness. Now, what is a moderate to severe illness? Well, unfortunately, the package insert doesn't say. So typically we say if you have fever or have presented with an acute infection, so it's a new onset otitis media or a UTI or a pneumonia, we're probably not going to give you immunizations that day. Now, if we're rechecking an ear infection that you've had and it's persistent and you're not having acute fever, it's probably fine to go ahead and give the immunizations. But we also have to factor in patient transportation, likelihood to return for follow-up to get those immunizations. There's a lot of factors that go into making those decisions. Other contraindications would be a patient on chemotherapy or severe immunosuppression, either induced by medication or based on the patient's medical conditions. We have some patients whose parents are on active chemotherapy, and we should not give those patients live virus vaccines at that time. But typically we rely on the parents' oncologists to advise us as what's best in those situations. Because certainly we can't have a child getting chickenpox while the parent's going through chemotherapy. So is it better to give them the vaccine or to risk the child getting chickenpox? But we usually rely on the parent's oncologist to advise us what's best in those situations. Other contraindications, rare complications happen rarely. Occasionally you'll have a child that's allergic to latex, and the stopper in the immunization bottle has latex in it. So you may have a child that has a history of Guillain-Barré syndrome and shouldn't have this or that vaccination. But again, those kids should have very specific instructions from their specialists that tell us what we should and should not do. For the most part, everybody should get all the vaccines. Yes, please, everyone get vaccinated. All right, let's move on to the next learning objective. Discuss the rationale for screening tests such as urinalysis, blood lead level, PPD, and anemia screening. So urinalysis is no longer recommended as part of routine childhood well child care. We only do it if there's very specific indications for it. Blood lead level, if you are in an area where they are at high risk. For instance, where I did my residency in Kansas City, everyone there was high risk for lead exposure. There was a lot of lead in the soil, and every child was considered high risk if they were within certain zip codes. So everyone got 2 screenings in their lifetime. In the part of Alabama where I practice now, most kids are not at high risk for lead. So we don't recommend routine screening unless there's other risk factors. The primary risk factor in this area is poverty or living in housing with old paint. So those kids do get a screening for lead sometime between 9 and 15 months typically. And that is universal if there are risk factors. So our screening for lead level is basically just asking those questions. Do you have any risk factors for lead exposure? If the answer to that is yes, then of course they're going to have this screening test. PPD, if there's a known travel exposure or a known family exposure, then they will have a PPD. Also, if they're going into a healthcare related field or starting college, then a PPD is often required. Otherwise, these are not routinely done. Anemia screening, the American Academy of Pediatrics, which you'll hear me say a lot, says that every child should have a screening for anemia between 9 and 15 months. Anytime during that time frame is fine. We do those in an office, just a little finger prick CBC, and away it goes to the machine, and we discuss those results with the parents. Developmental screening. The American Academy of Pediatrics recommends that kids have developmental screenings periodically throughout their life course. Now, we do always ask developmentally appropriate questions at every single well-child visit, but specifically it's important for us to ask targeted evidence-based screening questions at specific visits. In my office, we use the ASQ, the Ages and Stages questionnaire, along with the MCHAT, which is the autism screening form. There are also Denver developmental screenings, which are done by those who've been trained to perform them, particularly the behavior and development pediatricians and the psychologist. ASQ, I would say, is one of the more commonly used quick screens in most pediatric offices. It screens gross motor, fine motor, social, problem solving, language skills, which gives you just 5 or 6 quick questions in each of those subject matters. The parents bubble in the little forms while they're waiting for you. You review the film. We use dry erase boards for them. We review those quickly, tell the parents whether they're normal or abnormal, and make any necessary referrals while they're in for their well-child check. So the American Academy of Pediatrics recommends developmental screening for gross motor skills at 9 months, personal, social, and language skills at 15 months, and then another screening around 4 to 5, a more comprehensive screening, making sure that they're ready for kindergarten. Hearing screening should be done around 5 years of age, again, before kindergarten. And vision screening, we start 4 years of age, and both hearing and vision should be done yearly after those minimum ages. Okay, describe the components of a health supervision visit for newborns. Newborns, infants, toddlers, school age, and adolescents. So let's kind of do newborns and infants together. So on newborns, you're going to be looking for adequate weight gain, which is 30 grams a day, roughly, in a newborn once they're past that 2-week mark, because they're going to lose weight at first, and then they should regain that birth weight by 2 to 3 weeks of life. Sometimes it's earlier, sometimes it's later, just depends, but by 2 to 3 weeks of life, and then gain an average of an ounce or 30 grams a day, roughly. So when they come in for that newborn exam, I'm really going to be looking for jaundice. I'm going to be making sure that jaundice is looking better instead of looking worse. We're going to be making sure that their physical exam is normal from head to toe, and I'm sure you guys have been doing physical exams on newborns, which is awesome. Going to be looking for any chromosomal features or any dysmorphological features. That's probably not a real word. You know what I mean, though. Any dysmorphology, any abnormal facial features that would make us suspect syndromes in the newborn or in the infant period. That may be when we catch those things. Making sure all of their organ systems appear to be where they're supposed to be and appear to be functioning normally are really important as well. Making sure they're eating, drinking, pooping, peeing, all that good stuff. Also importantly, in that newborn and infant period are screenings for maternal depression and anxiety. We know that postpartum depression is very real and affects a lot of our parents, particularly those in stressful environments. We also know that affects bonding, and it can have an impact on infant growth and development. So it's very important that we're asking those kinds of questions and making sure that we're screening for those things. Postpartum depression can occur up to about 4 to 6 months of life. So we want to make sure in that newborn and infant period that we're asking those questions. Anticipatory guidance in that newborn period, making sure they're using safe sleep practices, back to sleep in their crib, on their back, nothing else in their crib, no crib bumpers, nothing else in the crib, got the ceiling fan on to help reduce their risk of SIDS. In infants, we want to make sure if they're mobile that there's, no choking hazards in their environment. As they start to explore more foods, we want to, again, make sure that there's no choking hazards around for them to ingest. Speaking of ingestions, we want to make sure that they can't get into anything that they shouldn't be as they begin to crawl and walk. Again, car seats, smoke detectors. We want to make sure that we talk about smoke detectors in that anticipatory guidance realm, really for any age. But let's go back to specific components of health supervision, and then we'll do anticipatory guidance at the end. Sorry, I saw a squirrel. I'm getting off track. Okay, infants, physical exam, anticipatory guidance, anemia screening as they approach that 9 to 15 month age range, developmental screening. Toddlers, same thing. They're starting to get their teeth, so make sure that you're paying attention to those. We're looking at the whole person developing. We can't ignore their teeth in their mouth. Making sure, again, that we go over safety and anticipatory guidance, emotional guidance. Toddlers and teenagers, that's why they're... That's why adults need stress relief. Let's leave it at that. Sophia, you know what I'm talking about. Anyway, that made the quote board. Tantruming, toilet training, making sure we really hit all of that anticipatory guidance. School-age kids, making sure we're getting prepared for school. Some parents have no concept of the fact that their children will be reading in kindergarten. So we need to make sure they know those letters before they go into kindergarten. They can write their name. They know how to hold a pencil. All of those things are really important. And then the teenage years, making sure we're giving parents coping strategies to survive. Parental mental health. Let's talk about that. Really looking at it from a whole family dynamic situation. We want to make sure the whole family unit is happy and healthy during all phases of the children's growth. So let's talk briefly about anticipatory guidance and what things we talk about. So when I approach anticipatory guidance, my first question is often, tell me what you're most proud of. What is your child doing well? And that's a good way to kind of open a conversation and to kind of make a relationship with a parent, particularly if it's a parent that you don't know. So tell me, what is your child doing well? And the parent will say, oh my gosh, I love their snuggles, or they're talking so well, or, man, he's really good at throwing a ball. As they get older, gosh, he's reading so well, or whatever they're most proud of. If they can't think of anything, then we probably need to go investigating their relationship with the child and that parental connection. Are they stressed out? Do they have a lot of those ACEs or stressors in their life? So next, I usually ask, is there anything you're worried about with regards to your child's development or, emotional development, social, anything? Is there anything you're worried about with regards to your child? And that can be anything from he hates brushing his teeth to why won't he eat broccoli to he has trouble pooping to, gosh, he's not really talking. I've seen that cover a wide range of topics. The next thing I ask is, do you have everything that you need to take care of your child? A safe place to live, plenty of food, all that good stuff. And that gives me an opportunity to approach those social issues and the stressors. And I've already built on a relationship, of tell me what you love about your child, tell me what you're proud of. And we've opened that door to have an open conversation. I can get in there and address those social issues. And then my last thing is the the depression screening. So how are you feeling, Mom? Are you having any trouble with that postpartum depression or anxiety? Please remember, we're always here for you no matter what kind of issues you face. And I think that's really important to say. Even as your child grows and develops, please remember that we're always here for you. So then at the end of the visit, I give my spiel on anticipatory guidance. There's very few things that we can say that are evidence-based. Let's start with those. The first is car seats. Kids are safe in car seats. It's really important that they ride in car seats, okay? They should always be in a car seat. Rear facing until 2, or until they outgrow the limits of the sticker on the side of the car seat, right? It's really important to look at those stickers on the side of the car seat. Even if their little legs are bent up or cramped up, they can sit crisscross applesauce, they'll be fine. You can then turn them forward facing after the age of 2 or when they've outgrown the sticker on the side of their car seat. We want to keep them forward facing in a 5-point harness as long as we can, again, until they outgrow the sticker on the side of the car seat. Once they've outgrown the labeled height and weight, they can go to a booster seat. That booster seat helps position them so that the lap and shoulder belt fit them properly. Once they outgrow that booster seat, when they're about 4'9" and 80 pounds. Now those measurements are for a standard passenger car, not for a big old pickup truck, not for even the dark side. Those are for standard passenger cars. So my kids are going to need to be bigger than that before they can come out of their high back boosters. So you want them to be able to sit in the seat with the shoulder strap properly across their shoulder, not their face or their arm, and the lap belt securely across their lower waist and hips, not their bellies, okay? And their feet securely on the floor. So that's how big they need to be to come out of their car seat. So the first thing we want to talk about is car seats. Next, smoke detectors. Smoke detectors save lives, period. If they don't know how to change their battery, if they don't know what to do, they need to call their local fire department. This is what the fire department does when they don't have fires to put out. They go fix people's smoke detectors, okay? So make sure to tell them that if they don't have a smoke detector or they don't know how to test it, that they need to call their fire department and they would be happy to come out and help them. Smoke detector saves lives. Hot water heaters should be set to less than 120 degrees. At more than 120 degrees, kids can be burned pretty well instantly. So let's say your toddler toddles in the bathroom and climbs in that bathtub and turns on the water and it's really scorching hot. If it's 140 degrees, he's pretty well going to be burned instantly. Less than 120, if he turns that water on, he'll squeal. You can run in there and grab him out, no burns. So we like for hot water heaters to be set to less than 120 degrees. And trust me, you can still get a really good hot bath at less than 120 degrees. I know, because mine are set to less than 120 degrees. We're all going to be fine. So hot water heaters are a really important discussion. Firearm safety. This has been a hot topic. Lord, down here in the South, people have guns and we need to talk about it. And I know the state of Florida got all up in arms about it. So instead of asking the question, I assume everyone has a gun. Okay, so I don't ask because that's illegal in Florida. And I don't live in Florida, I live in Alabama, but I still don't ask the question. Okay, so I say the gun in your home should be stored this way. I do not say, do you have a gun in your home? Okay, that's one, not my business. And 2, most people in Alabama honestly probably do, and whether or not they answer that question honestly, I don't know. So the gun in your home should be stored unloaded, locked, with the ammunition in a separate place. It needs to be in a gun safe. It does not need to be in your bedside cabinet. Unloaded, locked, with the ammunition stored separately in a gun safe. Okay, so we have that conversation with every single patient, every single family, at every single well child check. And you don't ask, do you have a gun? Doesn't matter if you have a gun or not. This is how your gun needs to be stored. And then we need to be talking to kids about firearm safety as well. So car seats, smoke detectors, firearm safety, making sure you child-proof your home is important as well. And then once we get into that adolescent or school age visit, I start talking about helmets. You need to wear a helmet when you ride your bicycle, eat your fruits and vegetables, wear your sunscreen and bug spray because the mosquitoes are all going to carry us off. We're all going to get Zika virus, so let's make sure we're wearing our bug spray. Brush your teeth every day, twice a day, see the dentist regularly. I usually recommend they make that appointment at the dentist at their 18-month visit. Adolescents, get the don't drink, smoke, or do drugs talk and practice safe sexual activity practices if you choose to do that. Not if you choose to be safe, but be safe if you choose to have sex. Yes, that. All right, so this is the end of block 1. I promise this is the longest one, though I'll be shorter than this. Okay, block 1 done. Email me with any questions.